How are you?
I'm good. It's been a busy weekend.
Yeah, what have you been up to?
Lots of things happening. Today was the EuroGP meeting that the Austin Hospital runs every year. Fantastic turnout. And also we've got the APCC meeting happening.
That's right.
In Melbourne.
Yeah, Tony Costello's meeting.
Tony Costello's meeting, and always attracts some big names. And
yeah.
We've stolen one of them.
We've stolen one of them. It was very nice of Paul Cathcart to drop out to the GUcast studio. Paul, welcome. Great to see you.
Welcome. It's nice to be here. Very nice. Thank you for inviting me.
Good to see you, Paul. And you did your fellowship in Melbourne all those years ago.
Yeah, back in 2010 and 2011, I was here with Tony and Declan. Had a fantastic time, and it's amazing to be back. Amazing to be back.
And have you been back since then, or is this?
So Tony very kindly invited me back to speak at the meeting in 2013, and which was quite good because I was able to update on some of the talks that I gave then. So, but not since 2013, and. Oh, it's fantastic. I was able to visit the Botanical Gardens, which is my favourite place in Melbourne. So it's
there
lovely.
you go.
Yeah, because he did a fellowship here, Renew, all those years ago. That's so right. He's been back on his old stomping ground. So what we want to talk to Paul about today is not just radical prostatectomy, but salvage radical prostatectomy, because Paul Cathcart has done more than 500 salvage radical prostatectomies.
It's amazing. I think, a lot of urologists would try not to do one in their lifetime. And here he is, having done 500 plus, and he still looks calm, collected.
It's crazy. And a lot of people haven't done 500 radical prostatectomies, let alone 500 salvage radicals. So we're going to pick Paul's brains about that, about his own experience and his approach to it. Patient selection, trying to optimize outcomes, tips and tricks. So stay tuned if you're someone who does, a lot of radical prostatectomies full stop, but especially if you are someone who looks after patients who've had radiotherapy or some sort of ablative therapy before, and then they need a salvage prostatectomy. And today's podcast is supported by our silver partners, Device Technologies, Renew.
Yeah, absolutely. Big supporters of GUcast.
They are. So a lot of the big pharmacology companies support the podcast. We're always grateful for them. But we have a surgical company, Device Technologies, look after the Vinci Surgical System here in Australia, New Zealand, and actually across the whole of Southeast Asia now, Device Technologies do. So thanks very much to them. They're great supporters of us, not just on the podcast, but at Peter Mac and Epworth and everywhere we work. So,
and really important because I think the robot technology and the robot platform has really made salvage prostatectomy possible for a lot of people.
That's what we're going to ask Paul about a bit, aren't we? Yeah. So Paul, you did a talk about this today in Melbourne about salvage prostatectomy. I think you kicked off by talking a little bit about, patient selection and how you find these patients. They're not all the same, are they? We've got the ablative therapies, different types of radiotherapy and so on. You talked a bit about the sort of imaging that is used to identify recurrence after these ablative therapies and so on. So can you tell us a bit about that at the start, about the population of patients who have biochemical recurrence after ablative therapy and they come into your clinic? You've got a dedicated recurrence clinic, I think, at Guy's and St. Thomas's.
Yes. So we have a recurrent prostate cancer clinic where anyone who is potentially suitable for a salvage prostatectomy comes. The biggest issue is often patients are diagnosed quite late with their recurrence. So obviously the Phoenix criteria is used, the PSA nadir +2, and that was designed to identify metastatic disease and death from prostate cancer. It's never designed to look for local recurrence. So by the time they've met that criteria, they've already lost the window to some extent of curability. And the data would suggest a high proportion of those actually have micrometastatic disease. So one thing I would say to radiation oncologists listening is if they have a young, fit guy whose PSA is starting to trend upwards, which is still well below the Phoenix criteria, if it's gone 0.5, 0.8, 1, maybe think at that point to consider imaging. And the best imaging we've found is PET CT to look for local recurrence. And if a patient is fit and potentially up for it, then I'd be delighted, or they should be seen by someone who offers some sort of salvage treatment. I said in the meeting today that one of the most important things is working a multidisciplinary approach because there are pros and cons, just like with primary treatment, about the treatment options for men considering salvage therapy. And salvage prostatectomy is by far not a treatment for all men with recurrent disease.
Yeah, I mean, like we've been saying, patient selection is really critical, isn't it? And so what's your approach to the patient that's sitting in front of you?
So we go through a few things. So obviously the most important thing to look at their disease prior to their radiation. So if they weren't a particularly good radical prostatectomy candidate up front, they're not going to make a particularly good salvage prostatectomy patient now. They need to have a long life expectancy of more than 10 years. And they need to have anatomical reasons that would make them a reasonable candidate. So anybody with urethral stricture disease, anyone with severe radiation cystitis, small contractile bladders, they are not good candidates for salvage prostatectomy. And they have to be incredibly motivated and accept that there is arguably a very high risk of complications, also arguably very high risk of incomplete cancer cure with salvage treatment. And as I say, I think it's really important to work in a multidisciplinary team, because ablation approaches in the salvage setting may well be a much better treatment option for that patient with recurrent disease.
Yeah, so I think we can't be too blinded by what's the PSA doing, what's the imaging showing. You have to think what are this patient's goals, what are their expectations, and can we meet them with a quite potentially morbid operation. So you mentioned PET-CT, that's what we use as well, PSMA PET. We moved to that many years ago over MR. And a question arises though, if you've got a raging avid lesion and the PSA is rising, do you need to do a biopsy? Do you need to re-biopsy these patients? Do you routinely biopsy everyone, or would you treat based on imaging alone?
So we always re-biopsy. I mean, there's lots of reasons why it may be a good idea to biopsy. First of all, when you do your biopsy, I tend to do them all under sedation, which allows me to do a proper EUA, which evaluates them. I also often do a quick cystoscopy to make sure they haven't got any stricture disease. Often they can have strictures that I don't know about. If you take tissue sampling, it's quite good to have that in the bank, because it may be that there are some genetic aberrations that are different, and it's a slightly different tumor than before. If I take out a prostate that didn't have cancer in it, being so morbid a procedure would be an absolute disaster. And not only that, I mean, this patient may be a candidate for focal treatment, and so you'd need to know the laterality of any disease found. So I think a biopsy will always
lots of reasons.
Yeah, lots of reasons.
All makes sense.
Yeah, I say it comes up because we all got so impressed with these super avid lesions in the biochemical recurrence setting, but we've had definitely 2 patients with super avid lesions and have had a very good targeted biopsy, and this is not prostate cancer. It may well be eventually, but I totally agree with you. You know, when we get sent patients like this, and it's often just with a PSMA PET-CT and other clinical, suspicion, we would never offer anyone a salvage prostatectomy without tissue. I think, Renee, would we?
Yeah, I agree. Absolutely. I mean, and Paul, you're so experienced, and you've done a lot of post-HIFU salvage prostatectomies. How different are they based on what treatment they've had prior? External beam radiation versus brachy versus HIFU?
Yeah. So any radiation approach is a much more complicated operation with a much inferior functional result and a much lower cure rate. So I would actually divide surgery after ablation, and I would stop calling it salvage prostatectomy. My numbers of salvage prostatectomy would go down a lot, because probably about well over half of salvage prostatectomies that I've done are after ablation. So they're completely different kettle of fish. Arguably much easier operation with a better functional outcome, albeit they can have a reasonable high volume, high stage disease. So in my series of ablation patients, 2/3 had T3 disease. So, but that may be a selection bias of who I operate on. But they're very different. Operating after ablation is much technically easier, I would say. The post-operative journey is much less fraught with complication, and they do much better. Where the radiation patients, it's much more difficult.
And within radiation, is there a difference in your experience between external beam versus low dose rate or high dose rate, or have you done any proton therapies?
So there's definitely, so all have slight intricacies. So by far the most difficult would be post proton. We've had about 4 post proton, and interestingly, posteriorly they weren't particularly stuck, but they're very, very stuck laterally, and incredibly poor blood supply, which I find incredibly hard to sort of correlate with the fact that apparently protons have fewer side effects, which certainly operatively that isn't being translated. So I would say protons are the hardest. HDR are probably the easiest, probably by far. And then external beam, they're difficult at different stages. So the bladder takedown, if they've had nodal radiation, it can be very difficult. You can get into the iliac vessels very easy if you're not careful. And not only that, is the bladder is tethered higher up, so it causes tension on the anastomosis. The external beam radiation patients are incredibly stuck around the seminal vesicles, whereas in the post-brachy patient, which got next week, the seminal vesicles are normally fairly virgin territory. Interesting, they normally have seminal vesicle invasion, the brachy patients, because they tend to fail at the base of the prostate and the tumour extends into the seminal vesicle. But the brachy patients tend to be very stuck at the posterior apex when dissecting out. The thing about salvage surgery is because you're going in operating after someone else has treated them, it's very much a mixed bag. So my colleagues guys do a fantastic LDR brachy, and they're by far much easier to salvage than other patients who have had brachy in other centres, because the distribution of seeds sometimes can be throughout the pelvic floor and involving the urethra. And indeed, when I get the PET scan, we can see the distribution of seeds
outside the prostate.
Outside the prostate. Yeah. And I will turn down a patient if they've got a lot of seeds outside the prostate.
Declan, I mean, you have got a lot of experience in salvage prostatectomy as well, and I still remember one of your videos where you fished out so many of these brachytherapy seeds, I think something like 21 outside the prostate. And I still remember that video of you cutting through the urethra and there it is, another seed.
Yeah. That's the worry, isn't it? Yeah, and I suppose this is a population of patients who have failed, essentially. That's why they're having this morbid surgery. But that's where all the morbidity is, Paul, isn't it? It's at the apex. And sometimes you're starting off a salvage prostatectomy. I had one last week, which was after external beam, but it was obliterated laterally at the at the endopelvic fascia and the levator ani. But with the brachy I did a few weeks ago, everything, as you say, around the base and the seminal vesicles was absolutely fine. Even opening into pelvic, everything fine, until it just got right up to the apex of the prostate, and there it is. But that's where all the morbidity is. This is the problem, is that's where the urethral stricture is going to be, and that's where the leak is going to be, and so on. So have you any tips and tricks, I suppose, is what I'm trying to pick your brains on. You've done a lot more of these cases than I have now.
So I've completely changed my technique, actually. And that was because I was getting anastomotic leaks. So the operation would be either difficult or whatever, but that didn't necessarily translate into poor patient outcomes. But what I was seeing is I was getting a cystogram at 2 weeks and I was having leaks, and then I repeat the cystogram 2 weeks later, the leak got worse, which is not something you normally see in the primary setting. And that's pretty disheartening for the patient and myself, because I know it's immediately going to correlate with a bad functional outcome. And we've even had a patient need a cystectomy because the anastomosis hasn't healed. So the reason why the anastomosis breaks down and leads to functional problems is ischemia and very poor blood supply. And so I was talking about this with the people from Memorial Sloan Kettering, and they're doing a lot of salvage prostatectomies. They've got some various trials which are leading into salvage prostatectomy. And they recommended that I stop using all diathermy on the anterior and posterior bladder neck. Now, normally, diathermy through both, but I've subsequently completely stopped. I divide the bladder, anterior and posterior bladder, without a single bit of diathermy. I just cut the bladder off, which bizarrely doesn't bleed. Doesn't bleed at all. The tissue planes look different, but actually are much easier. You do the entire seminal vesicle dissection without any diathermy at all, and then you proceed. And then when it comes to the anastomosis, I've altered my Rocco suture. So I like a Rocco suture, but the problem with the post-salvage prostatectomy is radiation. It doesn't close. That space doesn't close. So we do 2 lateral Rocco sutures, which just begin to approximate the tissues. I never do lateral plication on the bladder because they would always fall apart. So I would do a normal running anastomosis. But then when it became to the anterior bladder neck, I no longer suture to the urethra. I copy a technique that Marcus Grafen does. So he brings the anterior bladder to the puboprostatics and the DVC. And so that anchors down the bladder. And then I do an anterior reconstruction with the other end of my Rocco suture, which I've been leaving with a quill. And then I do various other sutures to suture to the lateral pelvic wall. And then finally, I reconstruct the urachus. And I put a drain in the space of rectius and in the abdomen. And the reason for that being is if even after all those sutures, I still get a leak, at least I have a controlled leak and I don't get urinary peritonitis. So I've had a couple of salvage patients. Anastomosis looked great because of poor tissue quality. They've leaked urine. They'll be on the ward for 2 weeks because they've got urinary peritonitis and they're really sick. Whereas if you close the space of rectius, it's purely controlled. Urine's coming out the drain, and you have a fit, happy patient, albeit they don't have a secure anastomosis.
Wow, that's great.
Wow, that's amazing.
I'm making mental notes as I go along there, Renew, to say, right, he does he does 2 Roccos. So you don't want to get it the whole way down if it won't go down, but at least it'll
otherwise
hold.
it just pulls out. Then
same as you have to have zero tension.
Yeah.
Because it seems to me that in terms of functional outcomes, if patients have incontinence afterwards, I mean, you can put a sphincter in and that's fixable. But the real problem is if they get bad strictures.
Exactly, because then they can't get their sphincter. So you've got to do everything you can to try and minimize stricture, and strictures come from leaks, of course.
Yeah.
So
and bad tissues.
So everything you can do, and it makes a lot of sense not to use diathermy because and the tissue looks much healthier when you just.
And are you aggressive at the urethra? Do you cut back to bleeding tissue, or do you?
Well, the urethra. So the problem, and you can try and work out on the MRI with fat suppression techniques what the quality of the urethra looks like, but notoriously the urethra is much worse. So we have MRI studies looking at pre-radiation sphincter length and quality, and pre-salvage prostatectomy, and the urethra shrinks markedly and becomes a much thinner avascular structure. So the urethra is an issue. It has a very poor blood supply, but I always divide it cold cut, and I try and maximize the length of urethra. But there's not much you can do about the quality. What I try and do is minimize the number of suture passes through the urethra, which that must cause some ischemia in itself.
Right.
I think Renew's point is interesting because sometimes you look at the urethra, and of course we're normally trying to maximize urethral length, like in Martini Clinic, and we love having a lovely, long, healthy urethra. But if in a salvage case, if it's all very strictured looking, that white, woody, dead tissue, and you're going to run a high risk of a stricture, and you've already counseled the patient to say, look, well, about strictures, but about incontinence especially. If you cut back, I think is what you're saying, Renew. If you say, well, look, let's keep going a little bit more to the pelvic floor to see can we get away from this woody, dead-looking urethra. And at least then, even if you haven't got good urethral length, you might avoid the stricture. And we accept that a sphincter may be necessary anyway, but at least you're not going to be battling a stricture for a year or two.
So we've definitely done that. And you can dissect the urethra a long way below.
Into the pelvic floor.
Into the pelvic floor. Makes your anastomosis a little bit harder. And the tension may be a bit greater. In fact, one of the worst complication or difficulty you can get in time of the surgery is when the bladder won't reach the urethra. And in that case, we've had 2 cases like that. We've had to close the cystotomy, where you've taken the bladder from the prostate, and then make an incision on the anterior bladder wall, and then you bring it down.
I've done that.
Which gives you a lot more length, but then of course it may not heal posteriorly where you've closed. But that's the technique, because when you're trying to do anastomosis that doesn't come together, your heart starts racing, and what are you going to do? And the solution is definitely to make an anterior cystotomy and bring it down.
Very interesting.
This is gold, Renew, for people listening out there, because you can apply some of these tips and tricks to just a difficult prostatectomy, a difficult pelvis. There's a lot of tension. There's a huge prostate, and there's a big gap. So I think all these tips Paul is giving us you can apply to other difficult cases.
What about rectal injury, Paul? Because that's a very feared complication from a salvage prostatectomy. What's your experience with that? And
so I have only had one rectal injury after salvage surgery, and it was in a patient who we did a salvage cystectomy on. And he'd had, it wasn't, interestingly, for cancer. It was a benign issue. He'd had LDR brachy with an external beam and developed avascular necrosis because of radiation toxicity. And I did the cystectomy, and everything was fine. And then about 6 days later, he opened his bowels and perforated his rectum. So I think that was an ischemia issue, whether I used too much diathermy or whether it just the anterior wall of the rectum was terrible. And that's one of the worst complications I've ever had, is lifelong stoma. So it never happened in the prostatectomy setting, has happened in the cystectomy setting. And I do, because of that case and for other reasons, when I counsel patients for salvage prostatectomy, I tell them there's a 1% chance of a complete catastrophe. And I tell them that if they have a rectal injury, it's probably a stoma for the rest of their life, and they will have problems with fistulas.
Yeah, luckily rare, but when it happens, it happens.
So let's hope your patient's getting through. Maybe no stricture. Catheter gets out after a couple of weeks. The other two key outcomes that patients are interested in, having got through the potential big morbidity, are what about long-term continence rates? What do you tell patients, and what sort of solutions can you have? And what about erectile function? Let's say they did have some erectile function coming into this, which many won't, of course, having had previous treatment. So what do you say to patients, apart from the initial perioperative morbidity, what about the longer term urinary and sexual function?
So I always under-promise and try to over-deliver. So I always tell them they have a 100% chance of impotence. Yeah. And so you can only win by getting a chap but it's incredibly unlikely. To be fair, as you alluded to, the incident or the incidence of erectile function in these chaps is very low. They're virtually all impotent, to be honest. Yeah. But if they're a younger guy, so the younger guy who's had LDR brachy, he's probably the only guy who's probably potent before his radical prostatectomy. And you can nerve spare some brachyes. I have found that you can nerve spare, but on the whole, certainly external beam, you can't nerve spare, and they often have relatively aggressive tumours, so they don't tend to be low volume 3+4 radio recurrent tumours. So I tell them they're all impotent, but they can have injection therapies, of course. One of my chaps recently had already had an implant prior to his salvage prostatectomy. We've done a couple of patients who've had implants. He had a malleable, which was very easy, straightforward.
No reservoir.
But it's more of an issue if you have a reservoir. You have to keep giving him an erection while you're doing the case to deflate the reservoir, to give you space. But so I tell them 100% impotence, but they can have an implant. With regards continence, I tell them 50% of patients will recover continence not requiring more than a safety pad a day, but 25% will leak and wear a couple of pads a day, but won't be too bad. And I tell them 25% of patients will need some sort of sphincter or be left incontinent. And I tell them if they are going to have any incontinence surgery, sling is not the solution. They need an artificial sphincter. I have spoken to people who have asked whether they can have an artificial sphincter, at least partially inserted at the time of radical prostatectomy. But I'm not doing that at the moment.
And then we're talking about robotic surgery, I suppose, for all of this. So your experience of all these more than 500 salvage prostatectomies is all robotic assisted, I presume, Da Vinci prostatectomy, or do you still do some open surgeries?
I definitely don't do open surgery. No, I haven't done open prostatectomy since before I came to Melbourne.
Yeah.
So I did about 80 or 90 open prostatectomies in my training. I really liked the operation. I did do some assisted with some salvage prostatectomies in the open fashion, but that's a long time ago. I think there are very distinct advantages of the robot over open. With an open prostatectomy, the first thing you do after dividing the DVC is divide the urethra, and you're straight down onto the rectum, which is the most dangerous part of the operation. You're much more likely to damage the rectum, I think, if you're doing an open prostatectomy. Where with the robot, you've already developed that plane at the base of the prostate, which is quite a long way from the rectum. So, and the vision, of course, is fantastic. I mean, the camera changes have changed over time. So I use a lot of 30 up now, whether that's with my nerve sparing or the posterior dissection. I really like the 30 up, so that's helped.
Very good. And I guess the point, Paul, of patients going through this quite morbid surgery is to hopefully get a cure.
Yeah.
So what do you tell patients in terms of their chances of being cancer-free and the risk of recurrence in the future?
Well, that's not particularly a great story either, to be honest, because so if you look at all the data, a lot of patients have micrometastatic disease. The lower the PSA it is before you operate, the better. But overall, if you look at Memorial's long-term 10-year outcome, about 40% are biochemically free of disease at 10 years. So the biochemical free survival rate is not particularly great. It's way inferior to primary prostatectomy. That said, if you look at mortality rates, only about 20% of patients have died at 10 years. So these patients are failing, but they're not necessarily dying of their disease. But the patients really need to know that they could go through a highly morbid procedure and not be cured of their disease. The question is whether the prostatectomy has, one, extended their life. We don't know that because there's no trial. And number two, whether having their prostate out has avoided local complications, because we do know that if you take out the prostate in radio recurrence setting, they're not going to have obstructed ureters. They're not going to have lots of hematuria, etc. So they're certainly protected from local complications of their disease progression.
And I suppose with the big increase in focal therapy and other ablative therapies in some countries, UK, London in particular, you've commented that those cases are less difficult and probably do a little bit better. Does it mean there are more salvage prostatectomies to do because of the growth of these sort of ablative treatments?
Focal is an interesting story in the fact that it's been around for a long time. It's been around for a long time. I mean, it's not that new. I mean, in London, focal's been being done for not long off 20 years. Over the last, say, 5 years, there's been dissemination of different units. So now in England, there's about 6-7 places doing focal therapy, where it was really just one for many years, 2 for the last 5-6 years, but now there's multiple centres. So I think undoubtedly there'll be lots more salvage prostatectomies after focal therapy. If more people are having focal, more patients are going to recur by common sense.
And do you think these cases should only be done by people who are experienced at salvage prostatectomy, or certainly high volume prostate surgeons? I tend to get sent them here. People don't like doing these cases, and we don't like doing them. The patients don't like having these cases, but at least they should be getting done by people with a lot of experience.
I would very much, so I would advocate that. I mean, I'm a believer in centralization, so I'm slightly biased, but I think all all surgery for recurrent disease should be done in super specialist centres, simply because a lot of these techniques that we've developed come from doing a high volume of cases. You don't want to be doing 4, 5, 8 salvage cases a year. You want to be doing as many possible. And it's also, to be honest, as the surgeon, you have to have broad shoulders because you do get complications. So having a high volume slightly offsets that, I think. So.
Yeah, that's very true. Did you think all those years ago, Paul, when you came here for your fellowship, that you'd be back here talking about the 500 plus cases?
It's fantastic. No, I'd love to have stayed here. It's a great country, great healthcare system, and I love Australia. So no, definitely.
You just liked hanging out with Declan, right?
He's a great mentor.
Renew, I remember talking to him. I bumped into him 6 or 7 years ago when he'd gone back to the UK, and he said, "No, what I'm really specialising in now is salvage prostatectomy. That's all I want to do." I thought he'd lost his marbles. I said, "What are you crazy for?"
Crazy.
But it's really, really great to hear of all this experience. And you've published nice data. You've worked with Mark Emberton. You've set up the RAFT trial, robotic assisted surgery after focal therapy. So you and your colleagues, as ever, are approaching it in a very, studious and academic fashion. So.
Thank you.
Yeah, nice work, Paul. Keep it up.
One last question. So it's Da Vinci prostatectomies you're doing, but I know in your centre at Guy's and St. Thomas's, you have the Hugo Medtronic robot, and you've had the Versius, I think, as well.
We have.
But do you tend to do these only on the Da Vinci system, or have you any experience with these other newer robots?
So a lot of my colleagues are evaluating non-Da Vinci systems. I'm purely a Da Vinci surgeon, so and don't have any plans really to change at the moment.
Very good.
Excellent.
Well, there you go, Renu. Did you enjoy that?
I did. Learned a lot.
Yeah, we talk about a lot of oncology on this podcast, obviously, but we every time we talk about surgical technique, we get a lot of great feedback from people. So
we don't often get the chance, and this is such a unique field to be specialised in.
Yeah, maybe when he's done 1,000 in 3 or 4 years' time, we'll invite Paul Cathcart back again. But Paul Cathcart, urologist and ex-Melbourneian fellow, Great for you to drop into GUcast today. Thank you so much.
And by the way, Paul, in your goodie bag is a little GUcast scrub cap. So for your next salvage prostatectomy, we would love to see that photo.
We should pull it out. Where is that scrub cap?
I'll be wearing that next Friday. So
Next Friday, you're going to wear it.
We got a post-brachy case.
So all podcast guests get a goodie bag renewed, don't they? So if you're watching this on YouTube,
full of lots of great things.
Goodie bag, and there you go.
Thank you very much.
His GUcast
scrub cap. You're the first recipient.
Oh, it's really? Well,
yes.
right. I feel honoured. Thank you very much. Thank you very much.
There you go. Hold it up to the camera. There we go.
Hold it up to the camera. Yeah. Sorry.
All right. Well, thanks very much again. Thanks to Paul, and thanks to our friends at Device Technologies who distribute the Vinci Surgical System around Australia and Southeast Asia. For supporting the podcast as ever.
Absolutely.
We'll be back soon again with some more great GUcast. Thank you.